Alrighty, so we can go ahead and get started. I think 34 questions for today. So we'll see how quickly we can get through those. I did schedule some extra time for today just in case we need it. So the first question I have is, when asked to describe the differences between ethnicity and race, what should the student nurse explain? A, ethnicity refers to a shared identity, whereas race is limited to biological attributes. B, ethnicity and race are actually the same and are based in cultural norms. C, ethnicity can be understood only through an ethnic worldview. And D, race refers to a shared identity, whereas ethnicity is limited to biological attributes. So the answer to this one is going to be A. Ethnicity refers to a shared identity, whereas race is limited to biological attributes. So ethnicity is going to be like our cultural heritage, like our values, language, geographical space, and racial characteristics. Um, whereas race is limited to those biological attributes shared by a group, such as their skin color or their blood type. So ethnicity and race are not the same thing. They're different. And race, for D, race does not refer to a shared identity. That one's just kind of switched from A. So the next question here, which statement may indicate an adult learner is likely to be resistant to learning? And I apologize, my voice is a little gravelly. I think I'm getting sick. So A, I do not know how to use the internet. Do you have any brochures? B, I think I can look it up on my own. C, can you wait until my wife is here to teach me about that? And D, I've gotten by just fine all my life without taking any medications. I don't need to know about them now. So for this one, the answer is going to be D. An adult learner that's going to be resistant to learning. So we're looking at those key words that are going to make us think this person's really not open to learning and is probably not in the right headspace. So D says, I've gotten by fine all my life without taking any medications. So this patient's obviously showing that they're not really happy with that treatment option. So this would be a good time to kind of advocate for a patient if it is that the patient wants to try a different method. But if it is the only choice for the patient, this is that time where we can kind of use that therapeutic communication to figure out what the best method for getting them to be open to learning. So for C, can you wait until my wife is here to teach me about that? That's totally fine. That person's willing to learn. They actually want their wife to be there to help them. It's really good to teach the families as well. I think I can look it up on my own. That one can be a little bit of a distractor, but D's the better choice. And then for A, I don't know how to use the internet. Do you have any brochures? This is still showing that the adult is interested in learning about their illness. So D is the best answer for this one. What should the nurse include when caring for a client of a different culture? A, enforce use of specialty practitioners. B, be non-judgmental in healthcare beliefs. C, instruct the client to take ordered medications. And D, enforce the use of Western healthcare practices. So the answer to this one is going to be B. We want to be non-judgmental in our healthcare beliefs. So we want to be open to hearing what our client thinks about health, about medication, about treatment. A lot of other countries have different worldviews and practices in regards to healthcare. And the Western healthcare practices are very medication focused compared to a lot of other cultures. So instructing the client to take the ordered medications, not the best answer. Enforcing the use of specialty practitioners, Also, just not the best answer. We can recommend specialty practitioners, but that one is a little bit off base for this question. And then we never want to enforce the use of our Western healthcare practices. Patients have autonomy. And so if they are not comfortable with the Western healthcare practices, they always have the right to refuse. And we want to be open to hearing their own healthcare beliefs, because a lot of times if we kind of work with those beliefs, we can get them to be more accepting of including those Western practices in with their own practices. And that can kind of be a good way to get them to trust you and to take those medications, for example, or treatments. The nurse is caring for a patient who has emigrated from another country. The patient is in need of abdominal surgery but seems reluctant to sign the surgical permits. What is one tactic that the nurse should use? A, determine the family social hierarchy. B, encourage the patient to sign the permits. C, call the physician so the surgery can be canceled. And D, impress on the patient that her life is in jeopardy. So the best answer for this one's going to be A. We would want to determine the family social hierarchy. So because this has to do with signing the surgical permits, in their culture, they or in their family, they might have somebody who is in charge. Maybe a more patriarchal society might have kind of the man of the house being the one that's in charge. So we'd want to kind of determine if there's any cultural or family considerations to why the person isn't signing the form specifically, because sometimes we can overgeneralize and think, oh, they're not signing the form, they don't want the surgery. But in many cases, it might just be that it's actually the signing of the form that's the issue. So for B, encouraging the patient to sign the permits, that's not within our scope. We always want to advocate for a patient, but we don't want to give them advice or, be like, hey, you should definitely sign this paper and get this surgery. That's not our job. Calling the physician so the surgery can be canceled. There's a better option for this one. We kind of want, as the nurse, to maybe do a little bit of investigating first to make sure that there's not anything else that we can do. And then impressing on the patient that her life is in jeopardy, that would not be appropriate. So we would want to try and determine the social hierarchy of the family. The nurse is performing a cultural assessment on an adult client. Which information should the nurse include? Select all that apply. A, the language spoken at home. B, the cultural or religious influences in decision making. C, the client's region or country of origination. D, the kinds of food and drinks the client prefers. And E, whether the client has insurance. So for this one, the answer is going to be A, B, C, and D. The only one that's not applicable is going to be E. So whether or not the client has insurance is not going to be part of our cultural assessment. The kinds of foods and drink the client prefers is going to be important for the cultural assessment. A lot of cultures have their own dietary restrictions, and that's something we actually ask in the BAT as well during our assessment is, do you have any dietary restrictions or preferences I should be aware of? One example of this would be the kosher diet that the Jewish religion uses. So this would be important to know for our client, because if we are bringing them food they can't eat, we might think, oh, they're not eating their food, when in reality it's because the food isn't within their dietary restrictions. We'd want to know the client's region or country of origination. This can help us understand some of those cultural aspects of the client. Again, the cultural and religious influences. So we want to ask the patient, are there any cultural beliefs that might be important for me to know regarding your care during our time together? And then the language spoken at home is also really important. Even if our patient is speaking to us in English, it might be important to ask, hey, is there a do you have a language that you speak at home that's more comfortable to you that may be better to use? A lot of times in my personal practice, we have a lot of Spanish speaking patients, and a lot of times they'll really try and speak to you in English. But when it comes to making those important healthcare decisions, it's our job as the nurse to get the interpreter and to make sure that the client is fully understanding the information that we're giving to them. So that's why it's really important to go over that. So A, B, C, and D are all components of that cultural assessment. Which of the following is true regarding the documentation of data? Select all that apply. A, document before administering medications. B, use acronyms sparingly. C, use concrete specific information. D, document as soon as possible. And E, write the patient's own words. So for this one, the answer is going to be B, C, D, and E. So A is not going to be the answer. We always document after we give the medication. This is super important. We don't document before because the patient can refuse the medication, something can go wrong. We always document after. And the reason is because also when we document it, it means that the patient got the med according to the record. So if you document that you administered the med and then there's a code on the floor and you run out of the room and then you end up leaving for the day, then the night shift nurse is going to think that you administered that medication when you didn't because you documented it before. So always document after. We want to use acronyms sparingly. There are a list of acronyms that are approved by the Joint Commission that you can use. It's really important not to use those acronyms such as QD is one of the acronyms we don't use. We need to say daily because that can be misconstrued. There's a lot of similarities between medications, between treatments, a whole bunch of different things. So it's really important that we use those acronyms only when they're the ones that are approved. Using concrete specific information, also really important. We want to be very specific and not broad. We wouldn't want to say like the client is doing well because that's pretty broad. We don't really know what that means. D, documenting as soon as possible. This is really important. Going back to what I said before, document as soon as you can, as quick as you can, so that anybody could jump in and take care of your patient and be up to date with that information. And then E, we want to write the patient's own words. We never want to document anything like, oh, the patient is being aggressive, because that's not objective, that's subjective. So an objective response would be the patient stated, quote, I'm going to throw this chair at you. That would be what you would want to document rather than the patient is being aggressive. So for this one, B, C, D, and E are all true and A, not true. Care that includes the nurse learning about cultural issues involved in the patient's healthcare belief system and enable patients and families to achieve meaningful and supportive care is known as A, ethnocentrism, B, culturally competent care, C, cultural imposition, and D, culturally congruent care. So this one is more of like a knowledge or definition question. So the answer is going to be B, culturally competent care. Culturally competent care means that we understand what our biases are, and that we are aware that there are other cultures with other beliefs and that it's important for them, for their health and for their patient outcomes, that we incorporate their cultural beliefs into their care. So ethnocentrism, that's going to be this kind of belief that all the other cultures are maybe less than, so that's definitely not going to be it. Ethnocentrism is, if anything, maybe the opposite. Cultural imposition, that's going to be kind of like putting someone else's culture on someone else. And then culturally congruent care, I don't even know if that's, I don't know what that is. So culturally competent care is the one. And that's really important. A nurse is documenting data about a healing wound on a patient's lower leg. The predominant exudate in the wound is watery in consistency and light red in color. The nurse should document the exudate as. So for this one, the answer is C, serosanguinous. So serosanguinous means that it has some blood in it, but is mostly that kind of serous fluid. So that sero is serous, and then the sanguinous is obviously sanguinous. So for serous, that would be kind of straw-like fluid. Sanguinous is bloody, and purulent is pussy discharge. So that's really important. I'm sure you guys have talked about in lab as well. For example, when we document urine, we document it using COCA, color, odor, clarity, and appearance, I think. Color, odor, consistency, and appearance, something like that. But it's really important that we document what the exudate, for example, looks like, so that we can keep track of how it's changing, especially for a wound. The nurse is given a pamphlet to read about how to manage their newly inserted central venous access device at home. What will be most important for the nurse to assess? A, ability to see. B, literacy level. C, fine motor abilities. And D, health beliefs. So this one, when I was in PCC, tripped me up. So the answer is A, ability to see. This one is, if anything, it's because it's just a little bit too easy, but we're giving them a pamphlet. So we need to know whether or not they can see, and you will find that you can go your whole shift and not know that your patient can't see. And then they'll be like, oh yeah, I'm blind. Oh, are you? Right? So you'd be surprised how often that will happen. So it's really important to make sure, hey, are you able to read this? Okay. Before you give them a handout. It's important to check their literacy level. This is also going to be really important. The health literacy of the general population is pretty low. So it's important that when we're teaching our patients that we're teaching at that 7th grade level, using layman's terms. We don't want to be using medical terminology when we explain things. C, fine motor abilities. They wouldn't really need that if they were reading a pamphlet. And then D, health beliefs. This would be important, but it isn't the best choice because this one's asking specifically about that pamphlet. And this is kind of like a teaching question. So the answer will be A, ability to see. The nurse is differentiating between a medical diagnosis and a collaborative problem. Which statements are correct? Select all that apply. A medical diagnosis is managed by nursing interventions. B, a medical diagnosis describes an illness or injury. C, a collaborative problem is determined by a medical diagnosis. D, a medical diagnosis identifies pathology. And E, a collaborative problem is managed by both medical and nursing interventions. So for this one, the answers are going to be B, C, D, and E. So a medical diagnosis describes an illness or an injury. That's what's going to be described by the physician. So physicians give medical diagnoses. An example of a medical diagnosis would be renal failure or bipolar disorder or hepatitis. Whereas we know our nursing diagnosis, which you guys haven't necessarily gotten to yet, but our nursing diagnosis is never going to be a medical diagnosis. So we're never going to have our nursing diagnosis be renal failure because that's not our scope to treat. Our scope to treat would be fluid and electrolyte imbalance or fluid overload or decreased renal perfusion. Those would be our nursing diagnoses. So C, a collaborative problem is determined by a medical diagnosis. This is true because a collaborative problem is because of that medical diagnosis and because of those nursing interventions that need to be done to solve that problem. D, a medical diagnosis identifies pathology. Yes, and this is the difference between a medical versus a nursing diagnosis. A nursing diagnosis isn't to diagnose the patient with a disease. It's to diagnose their needs for nursing interventions. And then E, a collaborative problem is going to be managed by both medical and nursing interventions, because a collaborative problem is one that includes the doctor, the physician, and the nurse. And this is going to be most things. We have a lot of things that we can do as nurses to help our patients. So it's important to be able to collaborate with these things. Okay, so this is going to be one of our examples of the put in order questions that might be on your exam. So the night shift nurse is giving report. The following statements are part of an SBAR report. Put them in order in the way the nurse will give the report following SBAR format. So A, lab results are pending. I've notified Dr. Michaels with the request to order a CT of the abdomen. Is there anything else you'd like to request or other suggestions for interventions? B, Tyler Wilson is a 15-year-old Caucasian male brought to the ER with complaints of abdominal pain and fever. C, Tyler's vital signs are currently the following. He continues to complain of pain, but states it is more in the right lower quadrant with positive rebound tenderness in that area. Tyler's vomited twice in the last hour and states his stomach hurts with movement. And D, Tyler's father reports he was awakened around 4 a.m. with Tyler complaining of unbearable pain in his stomach around his belly button. At that time, his temperature was 100.6. So this one's a little bit tricky, but the answer is going to be B, D, C, and then A. So let's go ahead and go through this. So SBAR stands for Situation, Background, Assessment, and Recommendation. So for this situation, this is giving who our client is, where they are, how old they are, and what that main problem is. So it's going to be B, Tyler Wilson is a 15-year-old Caucasian male brought to the ER with complaints of abdominal pain and fever. So immediately the doctor knows who we're talking about. They can pull up the chart, and they're aware of what that main issue is going to be. Then we'll go ahead and give the background. Tyler's father reports he was awakened around 4 a.m. with Tyler complaining of unbearable pain in his stomach around his belly button. At that time, his temperature was 100.6. So the background is going to be information that we as the nurse did not gather ourselves. And it also helps to put this situation into perspective. What happened leading up to this? And the background is very important. You will find in nursing, if you just have the situation, it could be a lot of things, and a lot of times it won't make sense. And then you hear the background, and all those pieces are able to kind of fall together. So a good way to differentiate between the background and the assessment has to be things that you yourself as the nurse did. So Tyler's vitals are as follows. He continues to complain of pain, but states it is more in the right lower quadrant, etc. So this is the assessment that the nurse made that's giving the SBAR. If another nurse did the assessment, that would be background, not assessment, because the nurse giving the SBAR did not do that assessment. So she would have to give her own assessment. And then recommendation, this one's going to be that the lab results are pending. I've notified Dr. Michaels with the request. Is there anything else you'd like to request or other suggestions for interventions? And during this time, we can also, for example, make that recommendation like, I'm recommending that we go ahead and prescribe an antibiotic, or that we go ahead and transfer this patient, for example. So the recommendation is always going to be what you're wanting to get out of this call, kind of. So number 13, which situation indicates to the nurse that the patient is ready to learn? A patient who reports pain of 9 out of 10. B, a patient has the ability to grasp and apply the elastic bandage. C, a patient with a below the knee amputation is motivated about how to walk with assistive devices. D, a patient has normal eyesight to identify the markings of on a syringe and coordination to handle a syringe. So for this one, the answer is going to be C. A patient with a below the knee amputation is motivated about how to walk with assistive devices. So this would show that our patient's ready to learn because they're interested in regaining that function back and learning how to care for themselves now with this new health situation. So for A patient reports pain 9 out of 10. We never want to educate or do a teaching of a patient when they're in pain. So if you ever see that as a question, it's never going to be when they're in pain, complaining of pain. It needs to be after we give them the pain medication. So for B, a patient has the ability to grasp and apply the elastic bandage. This would be assessing their ability to learn or ability to do the task, but not if they're ready to learn. And then D, a patient has normal eyesight. Again, this would be kind of like that B situation. This is something we want to assess, but it doesn't signal us that they're ready to learn. When they're ready to learn, they're going to be asking questions. They're going to be asking, how can I do this? How can I manage my disease? How will I live with this? Those kind of questions is what we're looking for. But the patient's not ready to learn, especially when they're in pain. A nurse is assessing a patient. Which information collected by the nurse reflects subjective information? A, clammy skin. B, agitated behavior. C, numbness of the feet. And D, coughing after a deep breath. So the answer to this is C, numbness of the feet. Subjective information is information that the client can give and that we cannot confirm. I can't confirm that your feet feel numb because that's within your own senses. I can confirm that you have clammy skin. I can see that you're diaphoretic, that you're sweating, that your skin feels clammy. Agitated behavior, again, something that I can see myself. We wouldn't want to document agitated behavior. We would want to document what they said or what they did. And then coughing after a deep breath, again, the nurse can observe this, so that would be objective information. So C, numbness of the feet. Another example of subjective information would be pain is subjective because we can't confirm whether or not that's true. It's not a fact. You discover that part of a client's lack of appetite has been due to a urinary tract infection. You ask his sister for more information about the home environment, activities of daily living, and medications. What type of information source is his sister? A, primary. B, secondary. C, private. And D, informed. So for this one, the answer is going to be B. She's a secondary source. A primary source would be hearing it directly from the person. So if me and, this person are talking and they tell me something, they're a primary source. But if they say, well, the other nurse told me, then they're a secondary source. Private and informed, those aren't types of sources. So those won't be the answer. So yeah, if it comes from, for example, like I said, his sister, that's always going to be a secondary source. If it comes from the patient himself, it's a primary source. A nurse is observing a client drawing up and mixing insulin. Which of the following findings should the nurse identify as an indication that psychomotor learning has taken place? A, the client is able to discuss the appropriate technique. B, the client is able to demonstrate the appropriate technique. C, the client states that he understands. And D, the client is able to write the steps on a piece of paper. So these different learning domains are going to be important for the exam. This is in the blueprint. So we'll know that psychomotor learning has taken place when B, the client is able to demonstrate the appropriate technique. So with psychomotor learning, we always want them to be able to show us themselves. So another example of this would be like with an EpiPen. So if a client we're teaching them how to use their EpiPen, we wouldn't want them to just tell us how to use it. That would be in the cognitive learning. But when they actually show us, that's when psychomotor learning has taken place. They're actually able, they have learned it and they're able to do it themselves and demonstrate it back to the nurse, which is known as known as teach back. So that's going to be the best answer for that one. A nurse is providing preoperative education for a client who will undergo a mastectomy the next day. Which of the following statements should the nurse identify as an indication that the client is ready to learn? A, I don't want my spouse to see my incision. B, will you give me pain medicine after the surgery? C, can you tell me how long the surgery will take? And D, my roommate listens to everything I say. So for this one, the answer is going to be C, can you tell me about how long the surgery will take? So this is another example of the client being ready to learn. They're interested in hearing about their surgery. They're requesting that information. So this would be a really great time to do that education. The other questions, for giving me pain medicine, that's not really showing that she's ready to learn. C would be the better answer. For A and D, those are kind of outliers. Those would not be the answer. Excuse me. But for this question, this is a good time. I found that when I first started doing exams and practice questions, things like the word mastectomy would kind of throw me off, and I would start thinking, oh, what's a mastectomy? What do I know about that? But it's really important to read the whole question and see, okay, the question's asking when is the client ready to learn? So it has nothing to do with being preoperative or with her having a mastectomy. It has to do with the statement. So those can kind of throw you off. So it's good to kind of read the whole question first and then see, okay, is it actually a knowledge question about this? Or is it something I can answer and not work myself up over? A nurse is caring for a client who's a Jehovah's Witness and is scheduled for surgery as a result of a motor vehicle crash. The surgeon tells the client that a blood transfusion is essential. The client tells the nurse that based on his religious values and mandates, he cannot receive a blood transfusion. Which of the following responses should the nurse make? A, I believe in this case you should really make an exception and accept the blood transfusion. B, I know your family would approve of your decision to have a blood transfusion. C, why does your religion mandate that you cannot receive any blood transfusions? And D, let's discuss the necessity for a blood transfusion with your religious and spiritual leaders and come to a reasonable solution. So this one's a really important question. Jehovah's Witness often will refuse blood transfusions. I've actually had a patient who it was one of my first PCC clinicals, and she was a Jehovah's Witness, and she let me know that she would not be taking blood products. And so I was able to get her that special band. They wear a special wristband that says they won't take blood products. So the response that the nurse should make is D. Let's discuss the necessity for a blood transfusion with your religious and spiritual leaders. This is a really great answer because you could just not even include the religious and spiritual leaders part, but that part really makes it culturally competent care. Let's go ahead and bring them in. I know how important your religion is to you. So let's see if there is any solution that we can come to with those leaders. We wouldn't ever want to ask why, which is why C is not the answer. For B, we never want to give any advice or opinions. That's just not appropriate. And we don't know if their family is Jehovah's Witness, they probably wouldn't approve. So that's not appropriate to say. And then for A, again, never giving advice to our patients. It is not our job to tell our patients what to do, and they always have the right to refuse and the right to that autonomy. And it's our job as a nurse to let them know that they have those rights. A nurse is discussing culturally competent care at a nursing staff in service. Which of the following information should the nurse include when discussing clients' cultures? A, nurses should focus on clients' cultures rather than race when providing care. B, nonverbal communication is important in few cultures. C, culture plays no role in determining when a client will seek medical care. And D, nurses should expect clients to adapt to the care provided regardless of culture. So our best answer for this one is going to be A. Nurses should focus on the client's cultures rather than their race when providing care. This is really important. We never want to focus on a client's race. That would be inappropriate. Their cultures, especially, we don't know just by looking at them what their culture is. So it's important that we ask and we do those cultural assessments, and we take that time to ask the patient, are there any cultural, spiritual beliefs that are important for me to know during our time together? So nonverbal communication is important in really all cultures. And a lot of cultures have different nonverbal communication. So it's important when we are communicating with our patients to pay attention to not only our own nonverbal communication, but theirs as well. So if they're looking uncomfortable or they're maybe not making eye contact, for example, we could kind of evaluate that and see if there's maybe some cultural aspects that have to do with it. Culture plays no role in determining when a client will seek medical care. Absolutely, that's false. Culture plays a really big role in determining that. And some cultures even have a bit of fear of the Western medicine. So it can really make a difference when you are willing to listen to them and what their cultural beliefs are. And then nurses should expect clients to adapt to the care provided. No, it's our job to adapt our care that we're providing to the client's culture so that they can have the best outcomes. Because truly, those the best outcomes come when we're able to individualize that care, so that patient-centered care. A nurse is preparing an educational program on cultural perspectives in nursing. The nurse should include that which of the following factors are influenced by an individual's culture. A, nutritional practices. B, family structure. C, healthcare interactions. And E, views about illness. I don't know if I said D, biological variations. But the answers to this one's going to be A, B, C, and E. So D is not the answer. Biological variations are not going to be influenced by culture because that is going to be, like we said, race. Races are those biological attributes. So factors that are influenced by clients' culture, their nutrition, absolutely. Cultures have their own nutritional practices, their own dietary restrictions. A lot of cultures don't eat certain meats or might not eat meat at all. Family structure, absolutely. This goes back to that question about the hierarchy. Different cultures have different family structures, and uncovering that family structure can be really important in helping your client make the decisions about their care. Healthcare interactions, absolutely. Like I said, they can have some, other cultures can have some distrust of the Western medicine or not really believe it's going to work or kind of be nervous. Especially some cultures prefer to have the same gender as practitioners. So that could be another example of maybe how culture influences those interactions. They may not feel comfortable with a male nurse or a male doctor if they're a female patient. And then views about illness, absolutely. Some cultures believe that illness is due to, bad choices, or that illness is due to other cultural beliefs. So that's also really important. You might not have any idea, and then you ask your client, and they might say, "Oh, the reason that I'm sick is because I did this terrible thing." So that's really important to assess how their culture views illness. At which point during hospitalization should discharge planning begin? So discharge planning is always going to begin at B, our initial assessment. And the reason for this is that we want to start planning how our patient can go home from the start, because that's our goal, is for the patient to be able to be independent. So It would not happen during the focused assessment. If you don't know, a focused assessment is just on a specific part of the body or system. We wouldn't start discharge planning after the discharge order is written because to achieve the discharge order, we need to have documented that all of those requirements for discharge have been met based off that discharge planning. What do we need the patient to meet for them to be able to be discharged? And then after the special needs assessment, not every patient will even have a special needs assessment, so that one's not going to be it. So the answer is always going to be right at the initial assessment. We already have that plan of care being established, and their discharge is already being planned. And you'll see that when you go to clinical in the electronic health record, you can see the discharge plan. A nurse on a med-surg unit is caring for a client who has a new prescription for wrist restraints. Which of the following actions should the nurse take? A, tie the restraints to the side rails. B, check restraints and assess circulation every 8 hours. C, pad the client's wrist before applying the restraints. And D, notify the provider to renew the prescription after 48 hours. So the answer for this is C. I included this one again. This is from like modules 1 and 2, but restraints is something you'll definitely see a lot because it is really important to know. So C, we always want to pad the client's wrist before applying restraints so that they don't get any trauma to their skin from the restraints. They can pull on them, especially if they're agitated. So we want to have like some padding there. We never tie the restraints to the side rails. We never tie anything to the side rails. We need to check restraints and assess for circulation way more frequently than every 8 hours, every 2 hours. And notifying the provider to renew that prescription, if you guys remember, after 24 hours, every 24 hours, that prescription needs to be renewed. And do not forget, restraint prescriptions can never be on a PRN basis. And PRN is one of those acronyms for documentation that is approved, and that means as needed. So we can never have restraints in there as needed prescription. It needs to be something that we reach out to the provider for every single time, and it expires after 24 hours. And so if you don't get that new prescription, those restraints are coming off. It also can't be a written prescription, which means like the client can't just have restraints prescribed to them for a period of time without any evaluation every 24 hours for every patient. A nurse enters a client's room and finds her on the floor. The client's roommate reports that the client was trying to get out of bed and fell over the side rail onto the floor. Which of the following statements should the nurse document about this incident? A, quote, client found lying on the floor. B, quote, incident report completed. C, client climbed over the side rails. And D, client was trying to get out of bed. So the answer to this is going to be A, quote, client found lying on the floor. So this one's really important. We can't document things that we didn't see ourselves. So the client's roommate reported that the client was trying to get out of bed, which is why D is not the answer and C is not the answer. We didn't see the client climb over the side rails, and we didn't see the client try to get out of bed. For all we know, the client's roommate could have pushed them out the bed. So that's why we never want to document anything we didn't see. What we saw was the client lying on the floor. And then for B, incident report completed. Absolutely not. We never document in the patient's chart about an incident report. Never, ever. But an incident report does need to be completed very timely after anything like this happens, especially a fall. A nurse manager is overseeing the care activities on a unit. For which of the following situations should the nurse manager intervene due to a violation of HIPAA guidelines? A nurse who is caring for a client reviews the client's medical chart with a nursing student who's working with the nurse. B, a nurse asks a nurse from another unit to assist with documentation for a client. C, a nurse who is caring for a client returns a call to the person appointed in the healthcare proxy to discuss the client's care. And D, a nurse discusses a client's status with the physical therapist who's caring for the client. So this one's really important, our HIPAA guidelines. This is protecting our patients' confidentiality. And this is something that we can also say to our patients if they are concerned about sharing maybe some sensitive information. We always want to let them know that everything they say is confidential. So the answer for this one's going to be B. You want to intervene when the nurse asks a nurse from another unit to assist with documenting for a client. Nurses on other units are not allowed to look at our patient's chart. You cannot look at other patients' charts that are not your patients, even if they're in the same hospital. That's a no. But for A, you can look at it if you're the student nurse working with the nurse because you're assigned to that patient. You can share information if the person you're speaking with is that healthcare proxy or the client has given that written permission that that person can know. Now, if this answer said the client calls the client's girlfriend and tells them about the client's care, no, absolutely not. The girlfriend has no legal rights and the client has not signed any form that says she can get information. So that would be a time it'd be inappropriate. And then D, a nurse can discuss the client status with other members of that interprofessional team. That's actually really important, that interprofessional communication. So D is okay. So B is going to be that one that's that HIPAA violation. A nurse is documenting the administration of a drug to the patient. She administered the drug at 2:35 p.m. How would the nurse document this in military time? And those are the answer choices. So the answer for this is C, 1435. I just wanted to include this because this could possibly pop up on the test. Everything that's documented is documented in military time. I have made this mistake myself using non-military time, but we always want to use that when we're documenting. And in the client's health record, everything will be in military time for you. So the answer is 1435. So if you guys don't know, you just add, it just goes 12, 13, 14. So 235 would be 1435. A nurse is reviewing the documentation of a newly licensed nurse. Which of the entries should the nurse identify as meeting the ANA standards of documentation? A, the client is now asleep and they ate most of their breakfast a few hours ago. B, the client vomited 240 milliliters of clear emesis but denies pain or nausea. C, the client reports not feeling good, but they look fine. D, the client has 8 to 10 sores on their body. So for this one, the answer is going to be B. The client vomited 240 milliliters of clear emesis, but denies pain or nausea. This is very specific, concise, and it's factual, which are really important factors of documentation. So for A, the client's asleep and they ate most of their breakfast a few hours ago. No, that is way too not specific. It's not factual. The client reports not feeling good, but they look fine. Again, no facts. D, the client has 8 to 10 sores on their body. I would count all of them and then document that. So B is going to be our best answer. We want to be as specific as possible. The reason we're documenting is not to just be like, hey, the client's not feeling good, they look fine, so that we can go back and read it later, but that this is a legal document. The client can look at their chart. Lawyers and everyone, if it were to go to trial, can look at that chart. So it's really important that we're very specific because at any time the client could take a turn for the worst, and we need to know those specific details. So even for eating most of their breakfast a few hours ago, you'd even want to be more specific than that. When we chart on how much of the breakfast the patient eats, it's by percentage. So 50%, 75%, 25%. So even that is too vague. Which situation requires intrapersonal communication? A, staff meetings. B, shift report. C, positive self-talk. And D, wound care committee meeting. So for interpersonal communication, the answer is going to be C, positive self-talk. So intrapersonal communication is communication within oneself. Interpersonal communication is between two or more people. So for shift report, that would be interpersonal, because that's usually between two nurses, the day shift and the night shift nurse. And then D, wound care committee meeting, that would be a group communication with many people at the same time. This would also be a staff meeting. Again, that's going to be a group meeting. And then the other type of communication is public speaking. And so that would be maybe if one of these answers was giving a speech or giving a presentation. So yeah, so intrapersonal is within, so positive self-talk. A client exhibits all of the following during a physical assessment. Which of these is considered a primary defense against infection? A, fever. B, intact skin. C, inflammation. And D, lethargy. So for this one, the answer is going to be B, intact skin. So primary defenses against infection are going to be things in our body that prevent infection from getting in or from us getting an infection. So fever, that's an inflammatory response to a foreign invader in our body. So that's not going to be a primary defense. Again, inflammation also going to be not a primary defense, that's secondary. And then lethargy, that's a symptom. So that also wouldn't be a good choice. So the answer is going to be B, intact skin. And that helps to keep the germs out. So for clients who have an open wound, they might be at risk for infection because that open wound allows organisms to get in. The student nurse asks when they should document in the electronic health record. The nurse knows to document during the following situations. Select all that apply. A, transfer. B, changing condition. C, the client asks for a cup of water. D, communication. And E, admission. So when do we document? We would want to document A, B, D, and E. We document admission, we document transfers, we document discharge, we document any ongoing care, we document changes in condition, and any communication with that patient. The client asks for a cup of water, the client asks for a blanket. We don't need to document those things. But pretty much everything else needs to be documented. If you did it, you probably should document it. The client asked the nurse why an electronic health record system is being used. Which response by the nurse indicated an understanding of the rationale for an electronic health record system? A, it includes incident reports. B, it includes organizational reports of unusual occurrences that are not part of the client record. C, it improves interdisciplinary collaboration that improves efficiency in procedures. And D, this type of system tracks medication administration and usage over 24 hours. So this one, the answer C, it improves interdisciplinary collaboration. So the electronic health record is really awesome. Where I am for clinical, we have Epic. So with Epic, you are allowed, or you're able to see all of the client's information, and everyone on the care team is able to see that. The physical therapist, the occupational therapist, the PCT, the provider. So it's really great because you're all able to access the same information. You can read over their notes. So something I like to do when I get to clinical, I always like to read the H&P, and I like to look through any of the important doctor's notes. And if I was on a post-op unit, for example, last semester, so I really like to read those post-operative notes from the OR. So you are able to see those other documents that weren't documented by you. So that's what's really great about the EHR. So organizational reports of unusual occurrences, those are never going to be charted in the client's chart. Again, incident reports never documented in the client's chart. And then the type of system to track medication administration and usage over 24 hours is the MAR, the Medication Administration Record. So that's what we use to track the medications. A nurse is beginning to use patient-centered care and cultural competence to improve nursing care. Which step should the nurse take first? So this is one of those which one first questions. So A, assessing their own biases and attitude. B, learning about the worldview of others. C, understanding organizational forces. And D, developing cultural skills. So the answer to this one's going to be A. The first step we take when we're working to be culturally competent is assessing our own biases and values. It's really important to be aware of that and what you think and any possible biases you may have, so that when you are in those client encounters, you can go ahead and check yourself and say, okay, maybe am I thinking this because of my own biases and my own attitudes that I may have, or my own personal beliefs, versus maybe what's best for the client and what my client believes. So it's really important that we're able to look within ourselves for those biases and attitudes. And those biases can really affect our patient care. So it's important we know. Learning about the worldview of others, understanding the organizational forces, and developing cultural skills, those are all important steps in patient-centered care and cultural competence, but they're not the first step. The first step we need to take is a look in the mirror, assessing our own biases and attitudes. The nurse makes an error on a paper chart. Which of the following steps should she take to correct it? A, white it out. B, write does not apply with the time. C, contact the nurse manager. And D, draw a single line. This one always makes me laugh because very rarely will you see paper charts, but my mom's, where she works, they use paper charts. So it's definitely possible. So with paper charting, we would D, draw a single line through it. Single line, don't scribble it out. Don't, scribble over it. Never white it out. You don't need to contact the nurse manager if you make an error. You would just write, quote, mistaken entry. You wouldn't write does not apply, and you would go ahead and include the date and your initials. And also want to note that in the electronic medical record, you can edit those previous entries and fix those errors. And it'll update that you edited it. So in terms of electronically, but when it comes to on the paper chart, one single line. The student nurse asks what the cardinal rule of documentation is. The nurse answers, A, never use abbreviations. B, if it was not documented, it was not done. C, you cannot make changes to previous documentation in the EMR. And D, if you forget to document something, you can ask the next nurse to do it for you. So for this one, the answer is going to be B. If it was not documented, it was not done. And this was bright red in the PowerPoint. And this is so true. If you didn't document it, no one's going to know it was done. And this is super important. If you leave for the day and the night shift nurse comes on and you didn't document that you gave those meds, the night shift nurse is going to give those meds. And so now that patient is going to have a med error. So if you do forget to document something, this was one of my practice questions when I was in PCC. You turn around and you drive back to the hospital and you document it. You cannot document or have someone else document for you ever. And definitely not like the night shift nurse or the next nurse. You need to come back and you need to document. You can make changes to previous documentation on the electronic medical record, which is nice. But the cardinal rule is going to be, if it wasn't documented, it wasn't done. And we can use abbreviations, but we only can use those that are approved by the Joint Commission, and we want to use those sparingly. Some examples of abbreviations we can use would be, like we said, PRN. Another one would be PO, which means to take a medication by mouth. That's an approved abbreviation. Oops. Okay, so the next question, which action can the nurse take legally when charting on a patient's record? A, charts in a legible manner. B, states the patient is belligerent. C, writes an entry for another nurse. And D, uses correction fluid to correct an answer. So the answer to this is going to be A. It's important that we chart in a legible manner, that we chart clearly, concisely, timely, as quick as possible, and factually. State the patient is belligerent. Nope, this is again going back to, we want to use those facts, we want to use those quotes. You will see some crazy quotes of what the patients say, but that is the way that we're supposed to document, because it gives that clear clinical picture. Whereas when we see the patient's belligerent, we have no idea what that means. Write an entry for another nurse. Absolutely not. We're not supposed to document for other nurses. Super important. And using correction fluid to correct the answer. Again, we never use whiteout, never ever. If you do make a mistake, just do that single line through. And the last question of the session, a nurse notices another nurse make an inappropriate comment to a patient. The nurse knows that widely held unsubstantiated beliefs that have no basis in fact are known as A, archetypes, B, discrimination, C, culture specifics, and D, stereotypes. So the answer for this is going to be D, stereotypes. I'm sure you guys are familiar with a stereotype, but a stereotype is just that idea that has no basis in fact. That's just people being, stereotypical. And that's something we never want to be. You never want to say those things. And you can definitely report if other nurses are acting that way. So some other important concepts, archetypes, those aren't going to be, they are, let me pull up the exact definition just so I don't steer you wrong, but these are kind of similar in all cultures. Let me see. I don't, but archetypes are going to be similar in all cultures, and they're not like negative like stereotypes are. Discrimination, that's going to be acting on prejudice. So prejudice is having beliefs towards other groups or cultures that are like negative, like you believe that they're less than, which is absolutely inappropriate. But acting on those beliefs, acting on that prejudice, that is discrimination. And that's really important. That's something we definitely need to report if we see that in the hospital. And then cultural specifics, those are going to be those specific cultural values or cultural beliefs that are from that specific culture. So that wraps up the review for tonight. Thank you guys so much for coming. I really hope I was able to help you. If you want the recording and the PowerPoint, go ahead and direct message me either on GroupMe, or you can send me an email at ericadeeb@USF. It was really great to get to meet some of you guys in the lab as well. So please reach out if you have any questions. I'll stick around for a few minutes in case anyone has any questions. So yeah, go ahead and ask if you do. If not, have a really good evening and good luck on your test, guys. You're gonna do amazing. So yeah, I'm gonna go ahead and end the recording.